Welcome back. Let's now continue our discussion of eating disorders. So, I would just like to make a quick comment about laxative abuse. So, another way that people can attempt to lose weight is through the abuse of laxatives. So, they can take large quantities of laxatives, usually stimulant laxatives, so things like senna, bisacodyl, sodium picosulfate, which increase intestinal motility, and the aim of this is that contents will be moved through the intestines quicker, and therefore there will be less time for digestion, less time for absorption, and therefore less calories will be absorbed from the food, and therefore it will help to lose weight. Now, in some definitions that you will see of bulimia, the abuse of laxatives qualifies you for a diagnosis of bulimia. However, as I've said, the definitions that I am giving you here are the common sense, actually clinically important, clinically used definitions, and in real clinical practice, the important qualifying feature of bulimia is the self-induced vomiting, because the dangerous electrolyte abnormalities, which we'll go into in more detail later, that can come from that, and the medical complications are the important criteria for the definition. Now, abusing laxatives, yes, it'll give you bad diarrhea, but it is nowhere near as dangerous as self-induced vomiting. Therefore, in my book, certainly, someone who is just abusing laxatives and not inducing vomiting in themselves does not qualify for a definition of bulimia. They may qualify for a definition of eating disorder not otherwise specified, so this one here, which is really any sort of disordered attempt at losing weight that does not qualify for either of these two up here, and certainly doesn't qualify for this one down here. We'll come on to that in more detail later on. So again then, in my book, and I think in common sense, commonly used clinical practice, to have this diagnosis of bulimia, you need to be deliberately inducing vomiting to get that, and the abuse of laxatives does not qualify for you for that. Of course, if you're abusing laxatives and self-inducing vomiting, that would qualify you for bulimia because the vomiting's there. But abuse of laxatives alone, I don't think will qualify, in my book certainly wouldn't qualify you for this, even though you will see definitions where that would qualify you for this. But the abuse of laxatives is nowhere near as dangerous, and it doesn't cause the same sort of problems as the deliberate induction of vomiting. So, let's go over then the medical complications of anorexia and bulimia. So we'll start off with the more difficult one, which is anorexia, which has a plethora of different medical complications. So how am I going to discuss this? I'm going to sort of tell you the story of the order in which these happen. So obviously the medical complications that you get from anorexia get more and more severe the lower your BMI is. You don't suddenly start getting complications the moment you go under 17.5. Usually, if someone has a BMI of, let's say, 17.2, they might be absolutely fine with that BMI. It's as you get lower and lower, you're going to start getting more and more medical complications. So the way in which I'm going to do this is I'm going to try and give it to you in the order that they will actually happen as the BMI gets lower and lower. So let's tell a story then. So let's have someone, so we'll draw a little stick man here, who is going to lose more and more weight and get a lower and lower BMI, and we'll go over the sort of medical complications that's going to happen to this person and the potential eventual cause of death if they get low enough BMI. So here we have our person. So let's say they can start off quite thin. So let's say they start off with a BMI of 19 and they decide that they're going to, for whatever reason, and by the way, this video is not going to go into the reasons that people do this. There is a huge number of different reasons that people do this. And as I said in the previous video, often they won't tell you the reason that they're doing it. It's a secret, it's personal, and they won't go into the reasons with other people. And if they do give you a reason, it's most likely a lie. If anyone tells you that they genuinely don't have an appetite, that is most likely a lie as well, unless there is some genuine medical reason that they don't have an appetite. But young, healthy people with no medical conditions suddenly genuinely losing their appetite is rare. Usually that is a fallacy that they're telling you for why they're not eating. So let's go through the story here. So this person's going to go lower and lower and lower BMI. So they were 19, let's say they've gone down to 17.5. So what's happening? They're losing their fat tissue, and their muscle tissue will also be starting to atrophy. So in the early stages, all that's going to happen is they're going to be losing all their subcutaneous and visceral fat tissue, and they're going to start to reduce their muscle bulk as well. So the muscle tissue will atrophy, it will get smaller and smaller. So if this was a male, then they might have had some muscles initially. Those muscles are going to get much, much smaller. Their arms and their legs are going to become much thinner. Let's now go lower. So we cross the 17.5 threshold, lower and lower, and then really you have to get, I would say, below 16.5 before other medical problems start occurring. And by the way, let's say that this person is losing weight in a reasonably slow fashion. So let's say that they're eating 3 meals a day, 3 controlled meals a day. So they're controlling their portion size, but they are still eating 3 meals a day. They're not doing long fasts because, as we'll discuss later when we come on to EDNOS, even people who maybe have a very high BMI, so let's say someone who is obese, BMI 40, if they were to perform a 72-hour water fast, so they don't eat anything, they just drink, that causes medical complications in itself. So extreme diets, so fasting, causes medical complications independently of what BMI you are. So we're going to say this person isn't doing that. They're not doing an extreme form of dieting. So they are eating 3 meals a day. They're just restricting those meals. So the meals are quite small, and therefore they're gradually losing weight. So we're just looking at the medical complications of a progressively lower BMI rather than the medical complications of fasting or extreme dieting. Let's say they now get down to a BMI of 16.5. So at the BMI of 16.5, things are going to start happening. The body is going to have broken down a huge amount of its fat tissue, and it's going to have reduced the size of most of its muscles now. So it goes into a energy saving mode. And the way in which it does this is it slows the metabolic rate wherever it can. And this means that people generally end up feeling cold all the time. So they'll be producing less heat because their metabolic rate is reduced, and therefore they end up feeling cold all the time. So I'll just write some of these complications down, or I'll type them. So let's again just reduce the font size here. So we'll do a smaller font size. So we're doing medical complications. So feeling cold would be one of the early ones. In addition, one of the first things to go is that the reproductive systems turn off. So think what the body is going through. The body is going through a period of malnourishment, starvation, if you like. One of the first things that the body can turn off to preserve energy is reproductive function. Indeed, the body thinks that there is a lack of food availability, and therefore, from an evolutionary point of view, this is not the time to be reproducing. If there's not enough food for you, then you certainly don't have enough food for offspring. So reproductive function turns off reasonably early on as the BMI goes lower. So in girls, they lose their periods, so they develop secondary amenorrhea. In boys, they lose their libido. They may even develop erectile dysfunction, not able to actually become erect. So I'll put this here. So in girls, it's amenorrhea and loss of libido. In fact, let's bring this down here. So cold, amenorrhea, and loss of libido. And we'll put also ED for erectile dysfunction in men. So these are complications early on as BMI gets lower and lower. As BMI goes further down, so let's now go down maybe to 15, what will happen is the cardiovascular system will become compromised. So one of the main things that consumes energy within the body is the cardiovascular system. The heart is continually beating, which requires energy, and pushing blood around the body. In addition, all the blood vessels have a vascular tone to maintain blood pressure, and that maintaining vascular tone requires energy as well. So let me just do a brief sidetrack into the cardiovascular system. So time to draw a picture. So we'll come up here. So this is going to be a very basic picture. So this thing in red here, this is going to represent the heart, which sits in the chest. And then coming off the heart, we'll have the great aorta. So coming off the left ventricle, here comes the aorta. I'll just make it look a little bit more convincing. So here it comes. That's the arch of the aorta, and then it goes down and will split into the two common iliac arteries at the bottom. And just drawing a few more coming off here, you'll have the brachiocephalic trunk, which splits into the right common carotid and the right subclavian. Here is the left common carotid, and here is the left subclavian. So just a basic picture of the cardiovascular system. So remember what's happening. The heart is continually taking blood from the venous system, which we haven't drawn on here, and pushing it into the arterial system. The arteries, they are elastic, but they also have muscle tissue around them, and they will stretch, but they have to... This is a complicated concept, and I want to make sure I communicate it to you properly. In order for blood to go up to the brain, which is incredibly important, these vessels can't be too stretchy. Imagine what would happen if these vessels were just really, really stretchy, flaccid, elastic. What would happen is the heart would pump the blood out, and all the blood would go down here, because these vessels would just stretch open, and it would just all go down here because of gravity. So you wouldn't get any blood going up to the brain. So it's really, really important that these blood vessels aren't too stretchy. They have to be quite taut, so that when the heart pumps blood here, there isn't enough give down here. The pressure's too high for all the blood to just pool down here, and instead it ends up being forced up to the brain. And that's really important. That's the concept of vascular tone. So I'll just write this here, or vasomotor tone, and that's achieved by there being muscle tissue as well as elastic tissue in the walls of the arteries. Now, those muscle cells that are in the walls of the arteries, they change their contractile status depending on the fluid status of the human being. So your blood volume changes on a day-to-day basis, on an hourly basis potentially. If you now buy a 2-litre bottle of water and drink it, what happens to that water? It gets absorbed from the intestine, and where does it go from the intestine? It goes into the bloodstream and increases your blood volume. Now, very quickly, the kidneys will work to pee that water back out and return you to your usual blood volume. However, for a while, your blood volume will be increased by that fluid that you have drunk. So your blood volume changes on an hourly basis depending on what you're drinking, depending on your hydration status. Similarly, if you go for a walk in the middle of the desert and forget to take water, and it's a 10-hour walk, let's say, you're going to become dehydrated, and your kidneys are still going to be peeing out fluids. Your fluid volume in your blood is going to go down, so your blood volume changes, is what I'm trying to say here. Now, the importance of that is that if your blood volume changes, the diameter of these vessels has to change also. Because if you imagine, remember what I've just said, these vessels have to be taut, but the problem with having them taut is if you just have them as a fixed size, they're not going to be able to respond to changes in blood volume, and that's the genius of it. That's why they have to have muscle cells in their walls that can change their contractile status and therefore change the diameter of these vessels so that they can change and adapt according to the blood volume status, the fluid status of the human being. If they weren't able to adapt their diameter to that, then every time you drank water, your blood pressure would go up too much, and every time you became dehydrated, your blood pressure would go down. So it's really, really important that these vessels are flexible. They can change their diameter according to the fluid volume status of the human being. Now, why am I telling you all of this? I'm telling you all of this because to maintain the muscle cells in the walls of these blood vessels in a contractile status requires energy. In someone who is trying to conserve energy, the muscle cells are going to stop contracting, they're going to become really flaccid, and then that initial scenario that I told you about is going to happen. The heart will pump blood into a system that's really just flaccid, far too elastic, and therefore it's just going to stretch to accommodate all of this blood, and therefore all the blood's going to end up pooling down into the legs and not going up to the brain, and that's a problem. So cardiovascular problems are going to come from anorexia. In addition, the heart requires energy to function. To beat powerfully and push a large volume of blood out requires a lot of energy. If you are trying to conserve energy, when the body gets to lower and lower BMIs, it starts to conserve energy by making the heart beat less powerfully, so it ejects a smaller volume of blood and also less frequently. So classically, people with anorexia will have very slow heart rates. So I'm just going to put this here. So bradycardia, which is the term for slow heart rate, and hypotension, which is low blood pressure. So I'll bring these up here. And I hope that you understand so bradycardia is very simple to understand. The heart's trying to conserve energy, so it's going to start beating slower. And you can feel that when you feel the pulse. It's quite amazing actually feeling the pulse of someone in the advanced stages of anorexia, because they can have really, really slow pulses, like pulse of 30, whereas it should be about 70 beats per minute. Hypotension is much more complicated to understand, and it has multiple different reasons behind it. One, the heart's beating slower, so blood is not being pushed into the arterial system as often. And remember what the way blood pressure works, that you have a systolic and a diastolic pressure. So every time the heart pumps blood in, that causes the pressure in the arteries to go up, and then it gradually comes down as the blood is draining out of the arterial system into the capillary system and then into the venous system. Then the heart beats again, and you get something like this going on and on. So the top blood pressure is the systolic, and let's get a thinner pen, is the systolic blood pressure, and the bottom one is the diastolic blood pressure. Now, if the heart's beating slower, and of course we talk about there being a mean arterial pressure, which is somewhere in between the systolic and the diastolic pressure. Usually we say it's the diastolic blood pressure plus a third of what's called the pulse pressure, which is the gap between, what am I doing? So the gap between diastolic and systolic is often called the pulse pressure. And we often say that the mean arterial pressure is the diastolic pressure. Oh, I keep clicking on the wrong things. The diastolic pressure plus 1/3 of the pulse pressure, so it would be somewhere around here on this diagram. Now, if you are going slower, then the gap between beats will be longer, and therefore in that gap the pressure will be coming down to lower levels, and then the heart will beat again. So if you imagine, let's say, drawing this graph here, that the graph that I've drawn so far, the heart's going at one rate, and let's now say the heart suddenly goes to a slower rate. Well, what's going to happen? If it's suddenly slowed down, then in that longer gap between beats, your blood pressure will drop further, then it will beat again, but it won't take you to as high a bit, and you'll come down like this, and then eventually you'll find some new equilibrium, but that new equilibrium will be at a lower diastolic pressure and a lower systolic blood pressure. So the heart going slower, common sense, if it's going slower, it's pumping less blood into the arterial system, and therefore the mean arterial pressure is going to go down. In terms of what would actually happen to this graph, it would tail away like this to a new equilibrium, which is going to be lower down with a lower systolic and a lower diastolic pressure. So bradycardia is going to contribute to a lower systolic and diastolic and mean arterial pressure. In addition, because of trying to conserve energy, the heart's going to be beating less strongly. You're going to have a negative inotropic effect, and therefore the amount of blood, the stroke volume that's going to be pushed into the arterial system with each beat is going to be reduced. So the pulse pressure is going to go down. So each time it beats, it's going to go up by less. So that's also going to contribute to bringing the mean arterial pressure down, and again bringing this whole graph down. And then finally, the loss of vasomotor tone, the fact that these blood vessels are all going to become slack because it requires energy to keep the smooth muscle cells in the walls of the vessels constricted. So they're all going to contract less, and those vessels are going to become, walls are going to become slack, and that means that blood is now going to pool down into the lower blood vessels and not go into the superior ones. So when you measure blood pressure, obviously you measure it in the vessels in the arms, and pressure there is going to be reduced. So the loss of vasomotor tone is another thing that contributes to hypotension. So what then are the symptoms of hypotension? It's going to make you feel weak because not enough blood is going to the muscles in the arms. It's going to make you feel maybe a bit tired because less blood's going to the brain, a bit sluggish, cognitively reduced, and if it gets bad enough, it may even make you feel faint, lightheaded, and you may even faint, particularly when you stand up, because when you stand up, obviously, gravity is not working in your favour then. Gravity is also going to be pulling the blood down into the lower limbs, away from the brain. So when you stand up, it's going to be particularly bad, reduced blood flow to the brain. And if the blood flow to the brain is reduced enough, that's what causes you to feel lightheaded and faint. So pre-syncope and syncope. So I'll just add that onto here. So syncope is going to probably be the eventual consequence of low blood pressure, and let me just sort this out. Low blood pressure and postural problems, postural hypotension. Next, finally, there are a huge number of other consequences of anorexia. I'm just going to talk about the main ones. One of the big ones that I don't feel like I can get away without mentioning is osteoporosis. So as you get to lower and lower BMIs, BMI of 15 is probably low enough that this will start developing. So classically, one of the features that goes wrong in anorexia is that they break down their bones, develop osteoporosis, which you shouldn't be doing at a young age. So remember the basic structure of the bones. If we draw a section of a long bone, the outer part is compact bone, it's solid, hard bone, and then the inner part is more like a meshwork, a web. You have these sort of spicules of bone, like so these white bits of bone, and then you have gaps in between the bone, and the gaps are where the bone marrow lives. So this is called cancellous bone in between. So cancellous. Whereas the bit outside is the compact bone. Now, in osteoporosis, what happens is that the bony portions in the centre here become thinner and thinner, so they atrophy away, and the gaps become bigger and bigger, and indeed the compact layer becomes thinner and thinner as well, so you end up with bones with much more holes in them where you've got the bone marrow, but unfortunately bone marrow isn't very strong, so that means that the bones become weak, higher risk of breaking, higher risk of fractures. So classically in anorexia, this happens, that you get osteoporosis in all of the bones. And unfortunately, this is one of the few consequences of anorexia that isn't particularly reversible. So once you've got osteoporosis, it's very, very difficult to reverse it. Even if the individual goes through nutritional rehabilitation, returns to a normal BMI, usually the osteoporosis doesn't ever repair itself. How do you prevent osteoporosis? Well, the same way as you would prevent osteoporosis in an elderly person, tablets with calcium in, and usually vitamin D. So calcium tablets, they're not pleasant to take. They're huge, great tablets consisting of calcium carbonate, so huge, great tablets of chalk, effectively, that you're taking, and usually they have vitamin D in, and the reason that they have vitamin D in is that vitamin D is required for the absorption of calcium. That's the main function of vitamin D, that the intestine needs it to absorb calcium. So calcium tablets is one of the major ways to prevent osteoporosis. The thinking is that, if you provide the body with loads of calcium, then it's not going to break down the bone, because the main reason that it breaks down bone is to obtain calcium. More extremely, you can put people on medicines called bisphosphonates, so the main one being alendronic acid, but there are others as well. Risedronate is another one, zoledronate, so alendronate is the main one, however. These are drugs that actually go and bind to the bone and prevent it from being broken down. I keep clicking that wrong button. So bisphosphonates, such as alendronate, these drugs bind to the bone tissue, they bind to the bone mineral, and they prevent it from being broken down. I just want to fix my presentation because I've messed it up by putting these strange, boxes. So there's one here, there. Ugh, no, I'm gonna call quits on that. So these medicines, they bind to bone, they prevent it from being broken down. They're very unpleasant medicines to take, however. Alendronate, you take it once a week, and it can cause horrible stomach and esophageal problems. It can really irritate the esophagus and stomach and cause horrible symptoms of heartburn and dyspepsia. So it's not a nice drug to take, but it does work, certainly to some extent. So osteoporosis then, a major complication of low BMI, and then the final one, the one that is actually going to result in death if you develop it, which is cardiac atrophy. So if your BMI goes low enough, and now we're talking really, really severe BMIs, so BMIs of 13, 14, really, really low. And at this point, people will truly start to look skeletal, they'll look gaunt, really, really unwell. If you get to these sort of low BMIs, what will eventually start to happen is the body's broken down all its fat tissue, it's broken down all its skeletal muscle tissue, it now turns to its final muscle to try and actually obtain some energy, and that is the cardiac muscle. So you end up with the heart atrophying, so the heart gets thinner, it gets smaller, it loses its bulk, and this can eventually lead to, this will obviously worsen the hypotension hugely. It will mean that the heart's now actually truly weak and is not going to be able to pump as much blood around the body. It can lead to you developing heart failure, which is the syndrome where fluid accumulates everywhere because the heart is so weak. It's something that occurs often in elderly people. Their hearts get weaker and they end up fluid overloaded because of heart failure, but it can occur in anorexia that they can become fluid overloaded because of cardiac atrophy causing heart failure. In addition, it will cause potentially horrendous hypertension to the point that you cannot actually get out of bed. Your blood pressure is so low, the point that we might even call it cardiogenic shock, and eventually what will happen is the heart will just stop beating, it'll give in, you'll go into cardiac arrest, and that will be the point that this disorder kills you. So, there we go, there are the medical complications of anorexia. We've been going for 30 minutes now, so we will have a break there. In the next video we'll talk about the simpler medical complications of bulimia, so it will be a much shorter discussion of the medical complications of bulimia, and then we'll talk about EDNOS, and then finally diabulimia, and I'm looking forward to discussing diabulimia. Diabulimia is fascinating.